Good morning, good afternoon, and good evening, everyone. I'm Shile Qi from the College of Computer Science and Technology, Nanjing University of Aeronautics and Astronautics. It is my great honor to introduce our work, Electroconvulsive Therapy Responsive and Cognitive Impairment Multimodal Brain Networks in Major Depressive Disorder. Here is the outline of my talk. Although ECT is an effective treatment for major depressive disorder, ECT cognitive impairment remains a major concern. The neurobiological underpinnings and mechanisms underlying ECT antidepressant and cognitive impairment effects remains unknown. This investigation aims to identify ECT antidepressant response and cognitive impairment multimodal brain networks and assess whether they are associated with ECT-induced electric field within an optimal pulse amplitude estimation. A recent ECT review paper summarized that gray matter increase in hippocampus, amygdala, and temporal lobe, white matter decrease in hippocampal white matter tracts are the most consistently identified brain alterations after ECT therapy. Previous studies demonstrated that hippocampal-dependent cognitive functions, such as declarative memory, were most adversely affected by ECT. In addition, working memory, verbal fluency, complex visual scanning, and cognitive flexibility can be adversely impacted following an acute ECT series. Our previous study showed that ECT response was associated with reduced FIOF in the prefrontal cortex and hippocampus, accompanied with increased gray matter volume in medial temporal cortex, thalamus, and hippocampus. However, they were not correlated with ECT-associated cognitive impairment. On the other hand, ECT electric stimulus has been viewed as the means to elicit seizure activity that causes changes in the brain. Here is another study found that the E field within amygdala and hippocampus is significantly correlated with volume change, but neither structural volume changes nor electric field was associated with antidepressant response. All the above results indicate that ECT treatment response and cognitive impairment networks might be separate. So here in this study, we aim to firstly identify ECT antidepressant response multimodal brain network. Secondly, identify ECT cognitive impairment multimodal brain network. And thirdly, compare the ECT antidepressant response and cognitive impairment networks. And fourth, validate the identified antidepressant response and cognitive impairment networks in two independent datasets. And fifth, evaluate the relationship between ECT field within these two networks with clinical and cognitive outcomes. And finally, determine the optimal pulse amplitude based on antidepressant and cognitive networks. Here comes the method. So in this study, a single-site clinical trial focused on amplitude of 600, 700, 800 MA, included longitudinal, multimodal imaging, and clinical and cognitive assessments were completed on the day before and within 1 week of finishing the acute ECT series. To reduce medication confounds, all subjects tapered and discontinued their scheduled antidepressant medications prior to the baseline assessment, but as needed medications were permissible for anxiety and insomnia. Adult patients with MDD investigated in this study were recruited from the University of New Mexico. Among all the cognitive methods, the verbal score had the most significant longitudinal difference between pre and post ECT. This means that the highest cognitive decline after the ECT series. The longitudinal differences between pre and post ECT reflected antidepressant response and cognitive impairment, that we can see from these p-values. All patients started with right unilateral electrode placement and were randomized and blinded to 600, 700, and 800 mA prior to the first ACT treatment. So according to the goals stated before, we performed the following analysis. Firstly, HDRS guided fusion was used to identify antidepressant response multimodal brain network. And secondly, cognition-guided fusion was used to identify ECT cognitive impairment multimodal brain network. And third, antidepressant response and cognitive impairment networks were compared to identify common and specific brain regions. And fourth, antidepressant response and cognitive impairment networks were validated within 2 independent datasets. And fifth, the relationship between ACT-induced E-field and the clinical responses were compared with correlation analysis. And finally, optimal E-field, optimal pulse amplitude were estimated based on the ROC analysis. So firstly, HDRS-associated multimodal component was identified that longitudinally discriminating between pre and post ACT and anti-correlated with the HDRS scores. So we can see that after the ACT series, decreased file in the superior orbitofrontal cortex and caudate were accompanied with increased gray-matter volume in medial temporal cortex, thalamus, and parahippocampus and hippocampus. Cognition-associated multimodal component was identified that longitudinally group discriminating between pre and post ACT and correlated with cognitive scores. We can see that after ACT series, decreased files in the superior orbitofrontal cortex, caudate, hippocampus, parahippocampus, and amygdala were accompanied with increased gray-matter volume in the medial temporal cortex and caudate. When comparing between antidepressant response and cognitive impairment networks, we found that files in superior orbitofrontal cortex and caudate increased gray-matter volume in medial temporal cortex were common covariant aberrations after ACT. Gray-matter increase in the hippocampus complex and the thalamus was unique in antidepressant response, and 5 decrease in the amygdala hippocampus complex was unique in cognitive impairment. Independent ACT dataset verified both antidepressant and cognitive impairment multimodal brain networks. They identified common brain areas between antidepressant and cognitive impairment networks were found to be correlated with both depression severity and cognition in independent cross-sectional independent dataset. So all the above identified similarities and differences between antidepressant and cognitive impairment networks were replicated on the subset of those subjects treated with right unilateral electrode placements. And finally, we found that E-field within these two networks have opposite effects with improved antidepressant outcomes and compromised cognitive safety. And the optimal pulse amplitude to improve both antidepressant and cognitive safety in ECT was estimated as 92.7 to 130.9 V per m from estimated from antidepressant response and cognitive impairment brain networks. So in summary, to the best of our knowledge, this is the first study to identify the neurobiological underpinnings underlying ACT antidepressant response and cognitive impairment multimodal brain networks. we found a large overlap between antidepressant and cognitive networks. The overlap in the hippocampal complex reflects different mechanisms with increased gray matter volume in antidepressant response network and decreased FIOF in cognitive impairment network. Further investigation with the E field associated with this trade-off between hippocampal gray matter and FIOF changes may serve as potential biomarkers to balance antidepressant and cognitive safety with ECT. Finally, the determination of the optimal E field within the hippocampal complex to balance gray matter, antidepressant, and FIOF cognitive changes to estimate an optimal individualized amplitude, which determines the E field strength, may improve the ECT benefit risk ratio. Finally, I would like to thank our lab's iBrain founding director, Professor Zhang, and our collaborators, Professor Calhoun, Professor Sui, and Professor Ebert, who contributed to collect the ECT data. Thank you for your listening.